We're going to begin our program with a good friend and real leader in the field, Dr. Roy Fleishman, professor of internal medicine at UT Southwestern. We've asked Roy to start off our program and to start off our pod or session on rheumatoid arthritis. Roy is going to tell us about future therapy in RA. Dr. Fleischman.
Yeah, so I'd like to thank Jack and Artie for inviting me to give this talk. They've given me 20 minutes. It should take about an hour and a half. But I'm going to focus in on, does this work? Yes. So here's my conflict of interest. And here's the agenda. So I redid this talk over the past week or two based upon the results of the Pfizer 1133 study, which I think is of great interest to rheumatologists. So I have in here some new molecules in development, which I'll discuss briefly. I am going to talk about treatment considerations of RA in 2021, focusing on the results of that 1133 study. And then I'm going to, if I have time, talk about possible new approaches to treatment. So I do want to show some of these slides. So this is actually a preclinical study that was at ACR. And in vitro studies do suggest that the pathogenic role for ACPA is in RA. But the proof of concept of this has been hampered by the lack of therapies that actually deplete ACPA in serum and synovial fluid. And what this molecule is a molecule that reduces ACPA. It does work. So you can read the slide, and the slide tells you about, sets it up. But what it is, an uptake of the aptamer nanopeptide by neutrophils. So the aptamer is something which is anti-ACPA. And it gets into the neutrophil, and this doesn't work, and it is bound, and it causes deactivation T cells, macrophage, and monocytes. And this is a very, very interesting concept, and we'll see what it really does in clinical trials. This is another very interesting molecule. This is a phase 1 study. So it's a very early study. And this compound is a bispecific antibody peptide conjugate, which inhibits both the COSL, which is necessary for T effector cell and follicular helper T cells, and BAFF, which is a survival factor for B cells. So it does both of those. And this was, as a phase 1 study, was actually a pharmacodynamic study. And you can see in the graphs on the bottom that it actually did what it was supposed to do in terms of the COSL receptor occupancy, the change in naive CD19 positive B cells, and it didn't affect memory cells, at least in this. And in this one study, they did some very, very non-specific changes in disease activity, but they looked at a change in the DOS28-CRP, patient global, physician global, and they did have some beneficial effect. So this bispecific, as it gets into phase 2, we'll see whether it really works, and hopefully it does, and we'll see what it does in phase 3. Very early, but a very interesting concept. This is another compound. So it's another JAK. It's a JAK1 selector compound. This study was done in China, Chinese patients, Chinese drug, and it did work. It was a monotherapy study. The primary endpoint was ACR20 response at week 12, and it did improve the DOS28-CRP. It did improve the HAC. There was a safety signal in the higher group in terms of cryptococcal pneumonia, herpes zoster. But in this very small study, they didn't see any VTEs, or malignancy, or MACE. And the reason I'm bringing this up is because when we discussed this at TREC, Peter Nash brought it up. It's a Chinese drug done in China, and it might be much cheaper than the JAKs that we have. I don't know if that's going to be true, but we'll see what it really does in phase 2 outside of China and what it does in phase 3. And this is another very interesting molecule. It's a Pfizer drug, and these were patients. It was a phase 2 study. in methotrexate incomplete responders. And it's an interleukin receptor-associated kinase 4, IRAK4. And remember that because there are several of these being developed. And it's a key signaling kinase for toll-like receptors and IL-1 receptors. So because it affects toll-like receptors and IL-1, it may be a value in RA, but also in SLE. And they had a very unique endpoint. Their endpoint was actually the change in the S-die at week 12. It wasn't change in the DOS-28-CRP. It wasn't ACR 20, 50, or 70. It's a change in the S-die. And I had an article published last year with Joseph Smolendin and Al Taha, where actually we looked at what separates the placebo from an active drug best, what metric. Is it a DOS-28-CRP? Is it a C-die? Is it an S-die? Is it an ACR 20, 50, and 70? And the best discriminator was actually a drop in the S-die. So this is a molecule where in this study, they used tofacitinib as a comparator. So you can't take a look at how it does versus tofacitinib. It wasn't head-to-head, but the molecule did have some effect. We'll see what it does in phase 2b and what the other compounds with other companies do. Interesting concept. And this is another new concept. It's a chimeric monoclonal antibody affecting CD22. And CD22 is a B-cell response regulator. So it modulates B-cell receptor and TLR signaling. So not only may it be useful in RA, but also in SLE. And they use several doses and several infusion times. And it turned out that the highest dose actually did work. It actually did work in terms of the ACR responses, but there was very little change in the DOS-28 from baseline with this drug, which is a little strange. And there was no difference in achieving DOS-28 less than 2.6 or less than or equal to 3.2 versus placebo, which is also very strange. So the question is whether this drug really works. And this is a compound which is probably coming. This is Oligosumab. So this is a monoclonal antibody against IL-6 directly, not against the receptor. And I'm showing some old data. It was from a phase 3 study. And it did have a good ACR 2050 70 response to DOS-28 CRP less than or equal to 3.2 and a C-die less than 2.8. So clinically it works. And the safety was similar to the IL-6 inhibitors. What was shown at EULAR this year was patient-reported outcomes. And again, it was effective. So the question is, so we have a third IL-6 inhibitor, a little different mechanism of action, but it affects IL-6. Do we really need a third? Maybe we do, but it is effective, and it probably is coming. And then one of the other things I want to talk about is the potential role for Gmcsf in rheumatoid arthritis. So Gmcsf, which actually works through JAK2, induces monocyte macrophage survival and differentiation, polarization, and enhances the release of inflammatory cytokines within the joints. It is elevated in inflamed synovial tissue in patients. And there are increased numbers of CSF producing T cells in synovial fluid, and absence of neutralization ameliorates joint disease. So it should be effective. There was a phase 2b study which was done, which did show clinical effectiveness when the drug was given in the proper sequence. By that I mean it had to be every week. It couldn't be every other week. But interestingly, in this study, even though the ACR 2050-70 did not do dramatically well when it was given every other week, there was a significant decrease in pain. And if you take a look at the graph in the bottom right, you can see that a significant number of patients had at least a 30% improvement of pain, which is a good result in a patient. And about 40% had a 50% reduction, which is substantial improvement. So it does affect pain quite well. They're doing 3 phase 3 studies now 2 of them against tofacitinib, 1 against abatacept. And there are a number of other JAKs in development. And so I have this list here and what diseases that they're being studied in. So I wanted to quickly do that. I want to talk about treatment considerations in RA. But before I start that, I do want to ask this polling question. So when you look at the evidence, the safety and efficacy of medication, what do you rely on? The clinical trial program, what's been found, the long-term extension studies only, the results of a meta-analysis, a network or other, systemic literature review, real-world data, ACR, EULAR recommendations, or your own experience. And I'm going to give you 10 seconds to fill that out, and I can't see the result. I was told, Jack, where's Jack? Yeah, you'll tell me the result. I'll be okay, let's go. 10 seconds. All right, let's see the results. That's a problem with polling questions. They take too much time. I can't see it. Do we have results? No? I don't care. So the answer to the question is you do want to take a look at the clinical trial program. You do want to see what happened in long-term extension studies. A meta-analysis, I think, is garbage because it depends upon how strong the meta-analysis is. A systemic literature review, I think, doesn't work either. Real-world efficacy has real problems, which I'll show you, but it does help you in terms of giving you a signal. ACR and EULAR recommendations are worthless, but your own experience is really, really important. I don't know how many of you got those right, but we'll see. So let's talk about treatment considerations in 2021. So it's unlikely that a new mechanism of action will be available this year. The ACR guideline EULAR recommendations generally equate starting either a biologic or a target synthetic after methotrexate based on studies done prior to 2019 when these recommendations were actually written. But the most recent studies show that most patients will do better with a combination of methotrexate and a biologic or target synthetic, not as monotherapy. Some patients do okay with monotherapy, but most combination. And if you have to use monotherapy, the best drugs are an IL-6 inhibitor or a JAK. We've shown with all 4 JAK inhibitors that are approved anywhere in the world that a JAK plus methotrexate is at least as effective as a TNF plus methotrexate. Upadacitinib, baricitinib 4 milligrams were superior, tofacitinib was equivalent, and filgotinib was superior. So the question was, should we consider using a JAK prior to a TNF considering the benefit risk? That's what we're going to talk about. So I want to give you some background, and this is really important. So this is the benefit of JAKs is well established versus biologic DMARDs, but what about the safety? So I'm going to talk about the results of the Pfizer 1133 study, which came out in the past couple of weeks. And all I have is top-line data, as you have, but there are things that we can see from that top-line data that we need to think about. The conclusion is not that JAKs are dangerous. Let me just start that out. The conclusion is not that JAKs are dangerous. We can't say that, and I'll show you why. So this is a malignancy, a systemic review of registries, and I want to point to the red. Compared to conventional synthetics, mortality, cardiovascular events was significantly decreased in patients treated with TNFs. So TNFs do decrease cardiovascular events and mortality. And anti-TNFs did not increase the risk of solid malignancy, either in patients with prior malignancies or not. The one that was most seen was lymphoma and lung cancer. That's what we see in patients with RA. So the conclusion was by reducing dramatically chronic inflammation in RA, which is what the TNF inhibitors do, anti-TNFs decrease mortality, MACE or cardiovascular events without significant increase in the risk of cancer compared to conventional synthetics. So this is comparison to conventional synthetics. Now, what's the correlation of RA itself and traditional risk factors and disease activity in the treatment with cardiovascular disease in RA patients? So rheumatoid arthritis, as we know for years, patients have an increased risk of cardiovascular events. And the risk correlates both with traditional risk factors, but also with markers of inflammation. An epidemiologic study suggests that several disease-modifying antirheumatic drug treatments for RA are associated with reduced risk of cardiovascular events, including methotrexate and tumor necrosis factor. So the epidemiologic studies show that cardiovascular events are reduced with methotrexate and with TNFs compared to a patient who's untreated. And it's been demonstrated that reduction in disease activity over time in RA is associated with fewer cardiovascular events. And there have been many studies that I've seen over the past 20 years who have shown that we can reduce cardiovascular events by treating rheumatoid arthritis appropriately. Now, we know for the past year, for sure, since the first part of the 1133 study came out about PE and VTE, but I want to bring you up to date here. So if you take a look at the graph on the right, patients with RA compared to patients who don't have RA, even if they're treated, now these are with conventional synthetics, even if they're treated, have twice the risk of developing a pulmonary embolus or DVT, a PE or a DVT. So the risk of a VTE is higher in patients with RA, even if they're treated with conventional synthetics, compared to the normal population. And this is an article which just appeared, actually. It was an abstract at EULAR, but it was just published, I think, in ARD. It's from Olander in Sweden, where they showed that the risk of VT is actually related to disease activity. So patients in remission didn't have an increased risk. But patients at high disease activity, and they used the DOS-28, I think it was the CRP, had twice the risk of a patient who's in remission. And if they had moderate disease activity, the risk was diminished somewhat. If they were in low disease activity, a little bit better. Remission was actually quite good. So now, this is all set up for tofacitinib in the clinical development program. What did we know about tofacitinib before we saw the 1133? So this is from Stan Cohn's publication on the entire program of tofacitinib. And this is malignancies in MACE. And you can see that malignancies in MACE have been described in the program. They have a relatively low incident rate, and they're persistent over time, consistent over time. They don't increase over time. As you take tofacitinib, you don't have an increased risk, according to this data, for both malignancies and MACE. And if you take a look at VTE and PE, it's the same. The VTE here is actually DVT and PE. Very low risk, but it's there, and it doesn't increase over time. There's not an increasing risk of cardiovascular events or PE or even cancer over time. And this is the Corona registry. And so this is interesting because now they're taking a look at tofacitinib, which is the dark dot, versus biologic DMARDs in the Corona registry. And they're looking at MACE, malignancies, and death. And you can see in the first column, which is MACE, that there is numerically less MACE in the TOFA compared to the biologics in the registry, but the confidence intervals overlap. SIEs, a little bit more with TOFA, but the confidence intervals overlap. Herpes zoster, as we know, is higher with TOFA. Malignancies are the same, non-melanoma skin cancers are the same, and death is the same. And on the right, I show you the finger plot with the confidence intervals, and according to this, the risk for MACE is lower with TOFA than with biologics. Herpes zoster is higher, everything else is the same. So this is a registry of regular RA patients in practice. This was what they saw for VTE, DVT, and PE, tofacitinib versus biologics, no difference. VTEs, DVTs, PEs occurred in both groups, and there was no difference. So that's what the Corona registry showed, that's what the clinical trials showed. And here's the Pfizer 1133 study. So this is what we all saw, or we should have seen, last month or the end of January. Pfizer announced the co-primary endpoint result from the 1133 study. Now, you have to understand the study. The primary objective of the study was to evaluate the safety of tofacitinib, both 5 and 10 milligrams, versus a TNF inhibitor. The TNF in the United States, in the United States and Canada, was adalimumab, and the rest of the world was etanercept. So they had two different anti-TNFs. And the patients had to have RA, and they had to have greater risk. So they had to be over the age of 50, and they had to have at least one additional cardiovascular risk factors. Because the co-primary points was MACE and malignancy. And what they stated was the results shows that these co-primary endpoints, the pre-specified non-inferiority criteria were not met for the primary comparison for the combined doses to a TNF. They didn't separate the TNF. Based upon the pre-specified secondary comparisons, there was no evidence of a difference between the two tofacitinib treatment groups. So if you just read this and you take a look at it and you read the top-line data, you don't think much about it, you say, oh, tofa is more dangerous than a TNF. Tofa is more dangerous than a TNF. But you need more information. So oral surveillance, or 1133, was specifically designed to assess the cardiovascular events and malignancies, and therefore subjects were required to be at least 50 years of age and have at least one cardiovascular risk factor, and they had to be on background medication. There were over 4,000 subjects who received the study treatment, and in the analysis of these 4,400 patients, 135 had MACE, 164 had malignancies. For tofacitinib, the most frequently reported MACE was myocardial infarction. We expect that would be the MACE event that you would see in patients with RA. And the most frequently reported malignancy was lung cancer, and we expect that as well. So if you go back into the literature and you look at the standardized incidence ratio of malignancy in patients treated with JAKs, any of the JAKs, it's 1. And the reason why it's 1 is because it's reduced for cancers like colon cancer and breast cancer, but it is increased for lymphoma and lung cancer. Those are the two cancers that still occur in patients with rheumatoid arthritis treated with any of our biologics. So the lung cancer was not surprising to me. And this is very important because this is what I'm focusing on. In those subjects with a higher prevalence of known risk factors for MACE and malignancy, that means the patients who are older. So it may not be a patient's 50 or 55 or 60. It may be 65 or 70 or 75. It may be that there's a subgroup of patients who are older who are at greater risk and smoke, right? Particularly when you talk about lung cancer and heart disease. So the risk may be in a subpopulation of this very specific population in 1133. And it was seen across all treatment groups. So that's something to think about when you see this fully presented. None of us have seen it fully presented yet. So I put this slide together this week, actually. So, no, I'm sorry. This is MACE, and this is giving you the results. And I want you to take a look at the third column. And the third column is this one, the incident rate. The incident rate is low for MACE. For TOFA, especially the 5, and for the TNF. Actually, for the TNF, it's lower than in the ATTRACT trial, which also looked at TNF. But numerically, it is higher with TOFA. But they're low. When you do the hazard ratio, you do that division. So you take 0.91 and you divide it by 0.73, you get 0.124. So the hazard ratio is higher, but the incident rate is still low. And I should have said that. in the beginning. So the way that this analysis was done was a non-inferiority, but they did not measure the lower bound of the confidence interval. All the FDA was interested in was whether the upper bound of the confidence interval would be greater than 1.8. And as you can see in the where I have the hazard ratio down here, the upper bound for the 5 is 1.91. It failed because it was higher than 1.8. I'm not talking about the 10 milligram because there is more risk with the 10 milligram. So I'm really just focusing on the 5 milligram. And then if you take a look at malignancies, you see the same thing. The incident rate is 1.13 versus 0.7, both low, numerically higher with TOFA than with the TNF, and the hazard ratio is 2.18, the upper bound, but the hazard ratio is 1.47. So that's where they come up with the top-line result. But you have to look at this in terms of low incidence of these rates anyway. So we calculate the number needed to harm, and you have to treat something like 400 or 500 patients to get one patient harmed. And then when you look at the number needed to treat to get an effect, it's something like 6. So it's the risk-benefit. And again, it's the upper bound. And this is the EMA assessment report of PE and VTE. And I actually wanted to highlight the incident rates, so the ones that are in the white. So in the top column, the incident rate for the TOFA 5 is 0.27. For TNF is 0.09. That's the lowest that has ever been shown in any analysis of the 0.09. The 0.27 is what you expect to see. That was not statistically, for pulmonary embolism, that was statistically significant. If you take a look at DVT, which is the next group, it was 0.3 versus 0.18. That was not statistically significant. Arterial thromboembolism was 0.63 versus 0.61. That was not statistically significant. Deaths of 0.57 versus 0.27 was also not statistically significant for the 5 milligram, but the PE was. But the rates are again low. So here are the current box warnings. So because of this, what the FDA did about a year ago was to add what's in red. All cause mortality and thrombosis with Xeljanz, 10 milligrams. It should have been 5. It should have been 10 milligrams. 10 milligrams. It should have been 5 milligrams twice daily. It isn't twice daily. Xeljanz 10 twice daily versus 5 with TNF. So what the FDA said was the 10 milligrams is not good. The 5 they're not worried about. And lymphomas and other malignancies have been observed in patients treated with Xeljanz. So we knew that before. Now, they did have a safety communication, and they've added increased risk of serious heart-related problems and cancer with arthritis and ulcerative colitis. And they are evaluating these results. They haven't changed the label yet. I'm sure they will, but they haven't. And then Pfizer communicated this to the community. So this is, I'm going to use this as my last slide because I think that this is important. So the meta-analysis registry clinical trial programs didn't reveal the signal for MACE, solid malignancy, VTE, PE, or death. None of those did. The head-to-head trial did. But now there are questions. So are these increased risks just in patients with RA? In patients in PSA as well, colitis? Are these risks lower with tofacitinib than an untreated patient? So now tofacitinib conceivably reduces the risk versus an untreated patient, just not as much as a TNF. Are these risks lower than a patient treated with conventional synthetics? They didn't check it just against methotrexate. So is tofa better than a conventional synthetic? Are these risks also elevated compared to other biologics? They didn't take a look at IL-6 inhibitors or B-cell inhibitors. Are these risks versus TNF solely seen with tofacitinib, or is it a class effect? And we don't know the answer to that. And assuming the results of 1133 are accurate and class-specific, does the small increase in risk, although statistically significant, change your risk-benefit assessment of JAK inhibitors versus TNF and other biologics? So another polling question, and it really was, will I still prescribe tofacitinib as I did? I will prescribe other JAKs. I will not prescribe JAKs. I won't prescribe JAKs at all. And we can talk about that in the discussion section. So I have 22 seconds, and I just want to talk about bioassemblies, and I'm over. There are lots of bioassemblies that are approved. They'll be available in 2024. I want to tell you just one thing about the biosimilars. So we know that biosimilars work, but the only reason for a biosimilar is if they're cheaper. And my feeling is I will certainly use a biosimilar if it is cheaper to the patient. I don't care if it's cheaper to United Healthcare if the cost to the patient is the same or more. If it's cheaper to the patient. And I think that this is something that we're going to have to think about, assuming that our current state of health insurance is the same. So, only a minute over.
Almost perfectly on time. I think that we have one question from the audience. I think we'll save the rest for the Q&A section. But Luis Ramos asks, what's the difference between Actemra and Oligosumab?
And oligosumab?
Uh-huh.
So the difference between Actemra and oligosumab, one starts with an A, one starts with an O. Actemra, tocilizumab, is an antibody to the IL-6 receptor. Oligosumab, right? Mm-hmm. Oligosumab. Oligosumab is an antibody to IL-6 itself. So it works on IL-6. It's like Enbrel and Remicade, all right? Like etanercept and infliximab, where one is a fusion protein, one's a monoclonal antibody to the TNF. But their effects seem to be similar.
One last question. Catherine Dow from the virtual audience asks, are IBD patients taking high-dose TOFA seeing high rates of VTEs and MACE?
Are
IBD, the ulcerative colitis patients who have an indication for 10 milligrams BID, are they seeing these events?
So the answer to that is, so I don't know the IBD program that well, but my understanding is that in IBD, the risk of VTE is much lower, the risk of MACE is much lower, and the risk of malignancy there would be colon, and that should be lower with TOFA, but I don't know about that population as a whole. That population wasn't looked at. When the FDA changed the label for TOFA, for the 10 milligram, they still allowed the 10 milligram induction in ulcerative colitis and then said that if you could, reduce to 5 milligrams. I don't know the answer.
All right. Thank you, Dr. Fleischman. That's great.